Thank you. So next is Dr. Sebastienne Cotte, who will be talking to us about mitochondria and cannabis. What's the hype all about?
Hello, everyone. Make sure it's working. Jessica, can you see me?
I can see you. I can't see any slides if you're sharing.
Okay. Let me share them right now. See if I can get that to work. Can you see both?
Yes, they look great. Thank you so much.
All right, perfect. Thank you very much. So my name is Sebastienne Cotte, and I'm going to talk to you very quick about Mito and cannabis, and what we know and what we don't know. And I've made this presentation pretty long. There's a lot of slides. I won't be able to go over most of them, but if you want to reach out later to get a copy of them, you can have it and keep it for yourself, and hopefully use it as a reference. So very quick, I'm just a dad. I'm not a medical professional. Thank you for calling me doctor, but I'm not a doctor. My dad, however, is a doctor. But I've been dealing with this Mito and cannabis thing since 2013. This is my little boy you see in the, with my wife, and then little boy Jagger. He has Leigh's disease. And we actually moved to Colorado. We live in Georgia. We actually moved to Colorado in 2014 to access medical cannabis for him. And we ended up staying in Colorado until 2015 when we were able to pass a bill in Georgia and move back. Even if the option we get in Georgia are much, much more limited than what's available in Colorado. I'm also a UMDF ambassador, so I've been dealing with this, being a Mito dad and a cannabis advocate for 10 years now. So what do we know about cannabis and Mito? Well, we don't know a lot. What we know is there's limited but promising research. The first research that I found was in 2013, so about a year I started being involved, and it was out of Germany. And it showed that cannabis can be a very powerful antioxidant. As we all know, antioxidant is good for to improve mitochondrial function. Ohio State University did a research study that showed that cannabis can actually reduce the inflammation in the brain of the rats and improve their cognitive function. As we all know, everything that is on the rat doesn't always relate. The animal model doesn't always relate to human, but that's a very encouraging study. What we also know is that as cannabis in the US and around the world is becoming more and more mainstream, now it's still illegal in a lot of places, it's still hard to get, but it's becoming more mainstream. We are actually seeing more and more research, and this is great because there's still a lot of things we don't know about cannabis and Mito, and some of the interaction, what it can do, what it cannot do. So this is absolutely a great thing when the research is getting more, increasing every day and every year. There's a lot more people doing research. Now, what do we know about cannabis and Mito? We know that what cannabis is not a cure for Mito. Cannabis can absolutely help with many of the symptoms that are associated with mitochondrial disease. Obviously, the big one, the one that everybody knows, the one that everybody got started with is seizures and the CBD and the whole weed documentary on CNN that showed little girls in Colorado that use cannabis CBD to reduce their seizures. So we know that. We know that CBD works well to reduce seizures in many people. There is even an FDA-approved drug called Epidiolex that is an FDA-approved CBD extract that helps with seizures. It can help with eyesight. It can help with muscle pain and cramping. That's mostly THC that does that. Now, CBD is a very strong anti-inflammatory, so it can also help a little bit. But mostly THC can help a lot. You can have a GI issue. A lot of people can take like a 1-to-1 CBD to THC ratio in a pill form, and a lot of people are seeing relief of symptoms like Crohn or IBS, and things like this. And then mostly it can improve homeostasis, which is the ideal state your body wants to be in to function at its best. And we saw many research showing that cannabis can improve homeostasis. Now, where this is getting very tricky is this is not like a medication that you can go to Walgreens and get for one, and then you take Tylenol because you want to reduce fever, for example. Cannabis doesn't really work like that. Cannabis is very individualized, and each patient responds to cannabis differently. This is why it's so tricky. What do I mean by that? I mean, some people are going to do great on CBD. They're going to take CBD, it's going to help them with their muscle cramping, it's going to reduce seizures, it's going to just make them feel better. Some people, however, CBD doesn't have any effect and they need THC. But in some people, THC can actually, in about 10% of the population, THC can actually increase seizures. So you have to be very careful, and you can't put everything into one basket. And unfortunately, with cannabis, there's a lot of trial and errors. And that is very difficult for a lot of people, because if you don't live in a legal state, or if you live in a limited access state where you don't have access to every product, I want to say, for example, Georgia, which is where I live, that only have a 5% cannabis THC limit cap. So you cannot get anything with higher than 5% THC. Then the trial and error is very difficult to do, because you are missing out on so many products that could potentially help you. So this is where cannabis is still tricky, and this is where cannabis is still going to take a while to become more mainstream. Even if it's getting better every day, it's because it's very individualized and it does not work for everybody the same way, and every cannabinoid is different. And there's so many of them. We're just scratching the surface really on cannabis those days. So those are the slide now. We got a few slides where I'm going to go pretty quickly over, but like I say, we'll be in the presentation, and if you want to get hold of the conference organizer, they will be more than happy to send you this presentation. Only the female plants, something most people don't know, only the female plant produce flowers. So everything you get, all the oil, all the topical, all the flower that you can smoke, the vaping, everything that comes from the cannabis plant comes from the female plant. There are over 750 components in the cannabis plant. Some of them we have no idea what they are or what they do, to be very honest. What we know is there's over 140 cannabinoids that have been referenced. That number goes up all the time, so it's probably even more than 140 right now. But there's very few of them that we have studied extensively and then we know what they are, and I will talk about those in just a second. So the most popular, the one everybody knows, the one that had a bad reputation, unfortunately, is THC. So THC was discovered in 1964 in Israel, and THC is psychoactive, so we can absolutely get you high. A lot of people use THC recreationally, but THC is an amazing, amazing compound, cannabinoid, also for medical reasons. It's a great muscle relaxant, a pain reliever that is so good for so many people. It can reduce nausea. It's an antioxidant as well. So THC can do a lot of things, but mostly most people will use THC, for pain and pain control. Now, there are studies out there, which is not the topic of today's conversation, but something which is interesting. There are studies out there showing that THC can actually fight some form of cancer. And there are a lot more people are doing research now with THC and chemo together, being able to do some amazing things. We're seeing some amazing results on THC and cancer right now. The second cannabinoid I want to talk about is the THCA. So pretty much in a nutshell, not to make this too complicated, but in the raw form of the plant, there is no THC. There is only THCA and all the A cannabinoids, CBDA, THCA, etc. Those are non-active. They're also sometimes called non-activated. When you heat up, either if you were to smoke it with a lighter or to put it in an oven, if you want to make, to heat it up to make a salve or an oil, once you heat up THCA, you are burning out the carbon atom, and THCA is becoming THC, which we'll just talk about, which is psychoactive. But THCA and THC actually have different properties, and they do different things. So THCA, we're finding out more and more now that THCA is very good for nausea, and a lot of chemo patients are taking, or patients with, maybe cycling, vomiting syndromes. THCA is helping to reduce the nausea. So THCA can do a lot of things. We don't have as much research on THCA as we do on THC, but it's getting very popular, and people are liking to look into THCA more because it's non-psychoactive. So this is the big advantage of THCA. And then, of course, the one that everybody knows about, the one that kind of started this whole cannabis revolution, if you want to call it that, is CBD. It's a product of the CBDA decarboxylation, just like I talked about before. The plant itself doesn't have any CBD, it has CBDA, and once you heat it up, it becomes CBD. It's non-psychoactive for the most part. It's a great anti-inflammatory, anti-oxidant, and antioxidant. The study then we show in Ohio State that it can be a neuroprotectant and it can help with some brain issues as well. But obviously anticonvulsives, the seizure effect, the anti-seizure effect of CBD, it's what's very popular. So, like I said, there's a lot more, many more cannabinoids, but for the sake of time, those are the one we're discussing right now. So how can you get CBD and THC and any kind of medical cannabis into your body? Well, you can smoke it or vape it. You can do dabs, which is usually more recreationally than medical. Edibles are getting very popular, but the problem with edibles is really hard to control the dosing because everybody digests and things differently, so it's very difficult. Oil, tincture, topical are getting very popular those days. Topicals are always a little bit tricky because anything you put on the skin, there's a lot of absorption issue with a different layer of the dermis of the skin. But topicals, they're getting better and better, and now they're having topical that can be very effective on muscle and joint pain, which I know a lot of Mito patients suffer from. So this chart here is a bioavailability chart. Again, I'm not going to go over in the great detail, but what you need to know pretty much is that inhalation, so smoking or vaping, is an immediate onset and it goes really fast. So if you have a crisis, for example, that would be what you do in a very bad crisis situation. You would want to vape or to smoke. Ingestion takes longer. That's why you take that when you do, like, for example, my son, it will take oil in his G-tube every day, several times a day, because I can control the dosing. I can control a little bit more of the duration and the bioavailability doing that and the onset. And you can take it under the tongue, sublingually, which is also a very fast, not as fast as inhalation, but a fairly fast way to take the oil. And then this topical, which is a little bit tricky, because we don't really know the bioavailability of topical and things like this. But it's the main way to get cannabis product to a patient. Now, very quickly, I got a few more minutes. I want to talk about some of the safety and side effect thing, because I don't want you to come out of this and think that cannabis is a miracle. It's going to help with everybody and everything. So there are a few things that you need to know. It can make you sleepy. That's normal. And if you're a new patient, it usually goes away after a few days. Depending on which carrier oil, if you're using an oil, safflower, olive oil, coconut oil, you could see some GI issue potentially from that. It's usually not from the cannabis, it's from the carrier oil. You do want to make sure that you have a clean and safe product. I'll talk about this just in a second, because it's a plant, and things can happen to the plant, especially when they grow outside. 10% of patients with high dose of THC, not just a little bit of THC, high dose of THC can actually have seizures. I discussed that earlier. And then the most important thing, and this is the reason why you should talk to your doctor when you start thinking about medical cannabis regimen, is because it does interact. It has a possibility, let me rephrase that, of interaction with P450 drug, which is a liver enzyme, which is a lot of the seizure medication goes to the P450. And there are different pathways in the P450. I don't want to get too technical. So just because it's a P450 drug doesn't mean it's going to interact with cannabis. Either way, it gets tricky with the interaction with medical cannabis. It does not always show. So what happens is you won't do anything to the cannabis, but it can increase or decrease the blood level of the other drug. So you could technically be reading a drug without even knowing you're reading it, because cannabis is reducing the availability of that drug in the blood serum. Or it could be increasing it, where all of a sudden you start seeing symptoms and people are getting, oh, what's going on here? This cannabis is doing a bad thing. It might not be the cannabis, it might be the other drug that the blood serum level is getting higher because of the cannabis, and therefore you're actually getting too much and you could go to toxic level. The way to fix that as much as possible is to separate cannabis with the other meds that can interact by at least 2 hours. But also, it's a very good idea to talk to your doctor and get a blood serum level of those meds before you start medical cannabis therapy. And then about 3 to 4 weeks later, do another one, and maybe 2 months later, do another one, to see how the blood serum level of the medication is being changed in your body once you are using medical cannabis. This slide just talks about pretty much how cannabis is actually a very safe drug. If we want to call it a drug, a very substance. The LED50 by ED50 therapeutic index is pretty much how dangerous something is. The lower the index, the most dangerous. Fentanyl is, I think, like 1 to 1 or something crazy like that. Cocaine is 15 to 1, morphine is 70 to 1. Cannabis is 40,000 to 1. in a nutshell, if you put this into a number form, it means that in order to have an overdose and die from cannabis, you will have to smoke 15 pounds in 15 minutes, which is obviously unrealistic. Therefore, medical cannabis is not a substance you can overdose from. Regardless of how you take it and how much you take, you cannot overdose from cannabis. And I have two more slides I'm going to do super quick. That is very important. Know where you get your product from, know where you come from, know if it has vertical integration, meaning the grower is doing everything, is growing, extracting, selling, or if it's something that is being transferred between different companies, because that's important to know. Look for organic certification on CBD product. About 5 years ago, the FDA, the Department of Agriculture gave organic certification to some cannabis product. Only CBD, no THC product. Know the extraction of the carrier oil, get some lab testing. This is very important. Get the lab testing when you buy your product. If the person selling the product does not have lab testing, a third-party lab, and they cannot provide you with those, then it's probably not a product you want to use, especially on a medical. Recreational is different. But on a medical atmosphere, on a medical side, you really want that. And then there's a law. Not everything is legal everywhere. There are registry in different parts of the country. If you your states have a registry, make sure you get on the registry. It will give you some legal protection. And finally, my last slide, I'm going to repeat a little bit of the thing. This is the main takeaways. I want you guys to go get the presentation. Medical cannabis is not a cure for Mito. How people tell me this is going to cure my son, my daughter. It's not going to do that. Okay, I'm sorry to disappoint, but there's no cure. However, it's going to bring relief to many Mito patients in the form of seizure relief, pain relief, better GI function. So that is going to help with that. Talk to your doctor and your medical team. I know it can be a little bit taboo, but as you can see with the interaction with the P450 liver enzyme, it's better safe than sorry. Try to talk to your doctor as much as possible. Not all products are equal, created equal, like I just said. I will not use personally a CBD product that is not USDA organic. There are enough USDA organic certified CBD product on the market today to be able to buy one that could be helpful for you. And for other products like THCA, THC, where there is no organic certification, get lab testing, get their microbial testing, get their pesticide testing. Those are the two main ones. I would get the microbial and the pesticide to make sure it's a clean product. That's it. I got done to everything. I tried to make it on time. It looked like I even finished with 1 minute early. So beautiful. I believe we have a Q&A coming up, so I will stay on and be happy to answer any question.
Jessica just texted me that her internet went out, so I think I'll overtake until she joins. Thank you so much, Sebastian. So let's see, we have a few questions in the Q&A. Sebastian, does CBD help with insomnia? We have tried trazodone and clonidine with no positive effect.
Yes and no. So what you want to try would be a compound, a cannabinoid called CBN, N like Nancy. It could be a little bit harder to find depending on where you live, but CBN is a compound that usually helps. We'll give that to my son every night to help him sleep. It seems to help a lot of people. Again, not everybody, but so CBN would be the compound, the cannabinoid you want to look for to help with sleep.
Thank you, Sebastian. Let's see.
While Sophia is looking for another question, Sebastian, I have a question. Do you have any books that you can recommend?
Oh, wow. Top of my head, probably not, but it's something that I can add a slide with some book in the presentation. So when, if you send it to people, I can put some there. I read many, but for some reason, on the top of my head, I can't remember.
Oh, that's okay. I know it's, yeah.
I'll get you a list of books. There are books out there which are helpful. The only issue with books on cannabis is because the research is evolving so fast. They become pretty obsolete fairly fast. And we're learning so much more. So I don't want to say obsolete. I want to say incomplete. They are incomplete. But I will get you a list of books to add to the presentation.
Thank you. Thank you.
Yep.
So I think this is a question for Dr. Parikh. Is vaccine safe for mitochondrial patients, especially for children who haven't received all vaccine injections?
I missed the first part of the question. Is what safe?
Is vaccine safe?
So yeah, so as far as we know, when a mitochondrial patient is in a healthy baseline well state, in general, we have not had issues with our patients, pediatric or adult, receiving any vaccine. If there are patients who are extremely fever sensitive, seem to wilt with fevers or take longer to recover, pre-treatment can be done, but most of our patients don't even need that.
Thank you. And there's another question for you. Is intravenous infection of ATP or ADP an ideal way to support mitochondrial disease patients, especially children, when the patient is suffering from repeated high fever, infection, or diarrhea? What about antioxidant drugs?
So is the first part of the question intravenous ATP?
Intravenous, it says infection. I'm not sure if it's supposed to say injection of ATP or ADP.
So to my understanding, I don't think we're there yet. I know people are looking at trying to somehow boost the number of mitochondria by something called mitochondrial transplantation, but we don't have that technology yet in a meaningful way that can be delivered safely. The antioxidants, again, oral antioxidants have been used historically, but the evidence is a little bit all over the place. Because we have seen some of our patients benefit, we will try a variety of antioxidants, and then some of my colleagues will continue them. Some of my colleagues, including myself, may say, well, maybe we're going to stop most of them. There are certain mitochondrial conditions where the brain does not get enough folate, and folate is needed for brain growth. There is a prescription form of folic acid that we use. There are some mitochondrial diseases where we know giving high doses of coenzyme Q10 can be helpful. Otherwise, we definitely monitor for deficiencies and for any of the antioxidants. If we need to correct those levels, we do try and correct them. We do not have any recommendation or guidance yet for intravenous antioxidant therapy. We really don't use intravenous therapy of any type regularly in our patients.
Thank you. One more question here for you. Will you consider adding something about the ketogenic diet for PTH deficiency in the standards of care?
Sure. And I can't remember if we included a line or if we removed it because we didn't have enough data. I think in general, from the ketogenic diet side of things, if we take all mitochondrial diseases, some patients respond, some patients worsen. There are certain mitochondrial diseases, including, of course, pyruvate dehydrogenase complex deficiency, where there are benefits noted. So selectively, it is something that is used, but it has not been the perfect diet or treatment for most of our patients. So we are very cautious. We have seen patients get very sick on the ketogenic diet when it's tried, even for something like seizure prevention, when it has been tolerated in other patients of that age. So we will always do this in the hospital setting with close monitoring.
All right. Thank you, Dr. Parikh. Let's see, there's a few other questions here for others. Jessica, do you want to take it over or?
Oh, Sebastian, could I ask a quick question about the cost of CBD? I know some of our families ask about not just CBD, THC, and we haven't always even tried what's available. And I know one of the barriers for some of our families has been the cost. And I don't know if you have a different answer.
Yeah. So the cost will vary depending on the state when you are, because a lot of the local taxes, and states love to tax cannabis because that's how they make a lot of money. Colorado, for example, is making literally billions of dollars in taxes over the last 10 years just in cannabis. For the CBD oil, about a 60 milliliter bottle, you should be able to get around $100, maybe $250. How long it's going to last depends on the patient, the weight. It's weight based very often, especially for seizures. However, they are I don't know if I can say name, but they are like Charlotte Rebs, for example. They do have the Realm of Caring, which is a non-for-profit that can help patient financially, and then Haley's Hope, which is the one we use for my son. They have the Flowering Hope Foundation, that help also with financial. So they are ready to get financial help for CBD. For THC, it gets a lot trickier because of the federal law being a Schedule I substance and all that stuff. You probably won't get a lot of help on the THC front unless it's a local dispensary. You live on, in the legal states, and then maybe the dispensary itself might have a program for low income. I know they do that in Florida, for example, or give a discount for pediatrics. But on the CBD front, if you go to the big one, they usually have a non-for-profit that help with cost. That can help with cost.
Thank you.
Yeah.
Thank you. Let's see. There's a couple of questions for Ethan, but I think he logged off. Here's a question for everybody, I guess. Dear doctors, is there any study on cure of CDHAF1 mutation causing respiratory chain complex 2 failure? Does anyone know? SDHAF1 mutation.
The question is there a cure?
Is there any study or any study towards a cure, I think?
I think a lot of different mutations and genes are receiving active study, but we do not have gene-specific or genetic disorder-specific treatments for all of mitochondrial diseases yet. Many of the treatments or drugs that are being developed by a variety of companies are sometimes trying to target the downstream problem, which is not enough mitochondria or not enough functional mitochondria, by trying to boost that number. There is some early research going on that will translate to non-human primates, which include apes and monkeys, that involve modifying the mitochondrial DNA. And hopefully in the near future, let's say 3 to 5 years, that these might get pushed forward, if safe, to human trials, but we're not quite there for most genetic diseases.
Yeah. Another question here in the chat: is ketone supplementation helpful for mitochondrial health?
As a whole, no. I know it's often kind of in social media and the lay public, there is talks about, both intermittent fasting, a ketone-filled diet, or ketone supplements, but none of those are necessarily outright recommendations for mitochondrial dysfunction or disease.
Thank you. Let's see if there's anything else. Yeah, I think these are all the questions. There's a few more for speakers who already left. So thank you very much. This was really helpful, and I think we're now moving on to the next session. So I'll give this over to Danielle Boyce. She's moderating the next part.
And just one comment for the person who posed the question about sleep: if only clonidine and trazodone have been tried, there's at least 6 to 8 other medications that we can safely try, even in young infants, that work, I would say, better than these much, much older medications and compounds. So I would hope that they might be working with somebody who's a sleep specialist, because they have access to some of these newer medications, which a neurologist may not. Clonidine and trazodone are medicines often started by neurologists, but there are sleep doctors who can be a bit more finessed about this.
Mm-hmm. There's a couple more questions that just came. I'll just read them because we still have a few minutes. So I would love to hear insights on how to treat neurostorming dystonic episodes. This is a huge ongoing challenge for our family.
Yeah, no, many of you parents or family members who deal with individuals with Leigh syndrome, it is one of the hardest things we have to deal with, and our medications often fall short. We usually will need multiple medications to help. If we're lucky, 2 or 3, sometimes more. There are side effects to those medications. Deep brain stimulator evaluations can be done. This is a surgical treatment, and they help to varying degrees, but they are not a perfect solution either. But it is something that, if quality of life is excellent outside of these, in between these, for the patient, it is something we absolutely consider. Not every center has a pediatric movement disorder expert where this is available, and then we sometimes have to tap in a colleague at a neighboring institution for that.
Okay, thank you. And one more question I think we can do. Are there any supplements or clinical trials targeting complex 1?
Most of the clinical trials, as I was mentioning, have not been complex specific, because many of these companies that are coming up with these investigational products are trying to have their medicine work for multiple purposes, multiple mitochondrial diseases, and even maybe mitochondrial dysfunction that happens from things such as aging. And so they really are trying to just boost the number of healthy mitochondria, or the improve the function of mitochondria that are there. And so they are not necessarily complex 1, 2, 3, 4 specific. They are more just trying to give the body ways to make more mitochondria.